Now we'll move to the last presentation of the session. Our speaker is Dr. Mohammed Al-Qahtani. He is a consultant transplant surgeon from King Fahd Specialist Hospital in Dammam. The title of his lecture is actually quite long, so we'll try then to... So the title is Expanding the Cadaveric Donor Pool for the Liver Transplantation Using Hepatitis C virus and HBs antigen positive grafts. Is it feasible? When and how? Dr. Mohammed. Well, let's another Dr. Qasim. I think that's what we have. Yeah, Mohammed Khan.
Yes, you did not instruct them.
What we have here, Dr. Mohammed Al-Qahtani, and different title.
Can I help you? Let's do
Sorry? Yeah, but the topic is different.
Okay. Yes, okay. So what is your presentation next up?
Sorry? But they did not inform us about these changes. Anyway, Dr. Qasim.
Actually, we're having a change in our schedule where we have Dr. Mohammed Khan, who will be presenting gastroesophageal reflux disease progress in endoscopic management. He's with us today to present instead of tomorrow. So just a minute.
Good afternoon, everybody. And I'm sorry for this change. I'm supposed to present my presentation tomorrow, but due to some unavoidable circumstances, Dr. Qahtani was unable to come, and I have to swap the lecture. So thank you very much for inviting me. I thank everybody, all the organizing committee, as well as the Dr. Fahd Sohaibani, the chief organizer, and hardworking. His hard work is always appreciated. So the topic of today is the GERD progress in the endoscopic management. And we'll talk about the latest guidelines which have been published in 2013. I will just mention you the important points which are mentioned in the last guidelines. So be remember, because it is different from the guideline which was published in 2009. And the first thing is, they say that the barium swallow should not be performed as a diagnosis of GERD, which is a common mistake by most of the general physicians. They ask the patient to go for the barium swallow to get the diagnosis of GERD, which is not diagnosed by barium swallow, it is diagnosed by pH monitoring. The second thing is, esophageal manometry is recommended before fundoplication to rule out any motility problems. And this is very important, that if you are sending your patient for any surgery, fundoplications, strata, or any intervention, you have to make sure that his patient has got a normal esophageal motility, either you do by high resolutions or not. The third thing is that preoperative diagnosis by pH monitoring is mandatory. So any patient who is going to have a surgery should have a pH monitoring, unless they don't have an obvious reflex esophagitis in endoscopy. And surgical therapy is generally is not recommended in patients who do not respond to PPI or those who have got a refractory GERD. So the current endoscopic therapy, or you have got a TIF, which is a transoral incisional-less fundoplication, cannot be recommended as an alternative to medical or traditional surgical therapy. So till 2 years back, it has been recommended that it is not the final answer to the gastroesophageal reflux disease. Now coming to the lot of things available, a lot of devices available in the market. There's a lot of money in this business, and as you see that there is a related to the radiofrequency ablations, related to the injections, or related to the suturing device. So usually we divide them in three broad spectrum of group of devices, and I will discuss one by one with detail, and particularly those who are in practice now. So the one which have been started with the numbers, if you see downstairs here, there is a 201 to 208. So most of these devices came in the last 15 years. So the first one which we discussed was the Enterix, which is a biocompatible polymer with a radio-opaque contrast agent dissolved in an organic liquid carrier. And upon contact to the tissue, it becomes a spongy mass, and you do it by under fluoroscopy, and the procedure is irreversible. The approval came for this Enterix in 2003, and what happened afterwards? When the things comes to the market, everybody take it and think that this is the answer. Then there started complications. Some of the major complications, few deaths. Patients developed pleural effusions, pericardial effusions, and some patients had aortic ruptures. So ultimately, the patient ended up with cardiac tamponade and had a surgery. So what happens last year that FDA say that you must have a warning, and the Boston Scientific Corporate has recalled all Enterix procedures kits, and they say that this injection is not advisable and it is out of the market. So Enterix story is finished. After using for 12 years, the Enterix is out. So I just put it in black, so Enterix is not there now. The second one is a gatekeeper. Also, it came with an interesting story. It started in 2003 when it came in the market. What they do is usually they put an implant, 2 to 6 implant at the lower esophageal sphincters, and by sucking the mucosa through the endoscope and then putting a saline in that and then putting an implant. And this thing came in the market. It was very exciting that you put an implant, it causes a stenosis, and then everything works nicely. But what happens, you see, after that, there was a prospective randomized trial which was run about more than 120 patients. And what they found that there are 4 reported serious complications of this gatekeeper, 2 perforations, 1 pulmonary infiltrates, another was having severe chest pain. So a lot of things came very exciting and then returned back that there are many complications. And what conclusion they made from this large trial? This was a sham and prospective trial. And gatekeeper procedures was associated with some serious but infrequent complications. And they did not find any statistical difference between the treated group and the sham group. So it was almost, there is no difference after the trial in between the 2 groups. And FDA warning came that stop using gatekeeper in 2012. So what happened after that? The second device which was used for the GERD is out of the market. Now coming to the third one, which is called DuraSphere pilot trials, and this trial came quite early in 2001. The trial came, and the DuraSphere is an injectable agent comprised of carbon-coated beads suspended in a water-based gel. What happens? It looks very excited that you introduce a gel and then it causes inflammations and local pressure effects and increase the LES pressure. But what happened after that? The side effect started. And then there was no further trial to support this DuraSphere trial which came in 2003. And what happened? That FDA did not approve it until 2015 because there was no further trial about this. So ultimately, the DuraSphere is out of the market. Now coming to the fourth injectable device is plexiglass, which is a microsphere for the treatment of GERD. And this conclusion came from the trial which was also published long time back, that endoscopic implantation of plexiglass into submucosa of the lower esophageal sphincter may be new method of treating GERD. But they say that the further trial is required, but there was no further trial was done because, as the injection material are going out slowly and the complications are becoming more and more, so ultimately no further trial study done, and the FDA did not approve the plexiglass also. So in summary of the injection devices, theory behind injection in GERD management is reasonable, but the clinical practice, their efficacy and safety has a poor outcome. The concern regarding accidental injections causing injury to the adjacent structures, such as aorta, lungs, and pericardium, is very serious and had a serious complications. So unclear whether mere passive, we don't know that whether if you inject something in the lower esophageal sphincter or lower esophageal end, you make a difference in the transient LES relaxations. So the things are not clear, and gradually the injectable devices are going out. So further research is needed before these technologies can be considered viable treatment option for gastroesophageal reflux disease. So till now, the injections is out. Now coming to the suturing device, how many suturing devices we have? There are 4 suturing devices which is available in the market. One is the endoclinch, the second is a plicator, the third is the Isofix X, and the fourth is the Medigas. Now coming to the endoclinch first, placement of threaded sutures at the GE junction, effectively clinching the junctions to enhance the barrier to the reflex. And as you see in the pictures that this is the step of the suturing of the lower esophageal sphincters. Around it, you make a multiple sutures and try to make a constrictions. What happened after that? That there are few studies came after this endoclinch. The first was a multi-center study demonstrated safety and efficacy up to 2 years with a reduction in symptom score, PPI dependence, and esophageal acid exposure time. So everything goes very nice, things work very well. Okay, this is one of the good treatment. But what happened, the same patients, they continued to have a trial for another 4 years, and they found that 80% of the PPI dependence and 64% of the treatment failure. So not a very good outcome when they continue following these patients. Now this disappointment came, they thought that the suture lost their tightness with time, and the endoclinch fails. The manufacturer has discontinued this advice, thus its future availability remain uncertain. So this device is also out of the practice. So coming to the next one is a Medigas. It's a company which is producing this device is Muse, and this Medigas is approved by FDA in 2012. And what they do is that they staple the system as you are doing a stapling in the papers. You staple the stomach with the esophageal ends over the lower 1/3 of the esophagus. After the Z line, you take 3 centimeters above, put the endoscopes down and retroflex and do a stapling. So after the stapling, it looks like as you are seeing a staple from outside, and you see the tightening of the lower esophageal sphincter. Recently there was a trial came which is a multi-central trial, and they say that if you see here that the baseline HQRL GERD score is much higher, and as compared to after the Muse endoscopic stapling device. So definitely it works, but we don't have a long-term effect of this device also. Now, in conclusion, there was a recent conclusion came that multi-center prospective study, the Muse stapling device appears to be safe, effective in improving symptoms, score, as well as reducing PPI use in patients with GERD. These results appear to be equal to or better than those of other devices. So they compare with the other devices. They did not compare with the fundoplication, but they compare with the Strata and the Isofix X. So we put a tick mark. So this is in the market. So still the Medigas is there, the stapling device is there, which is one of the possible treatment. Now coming to the second one is full thickness plicator, which came in the market quite early. But what happens that when it came in 2003, it ended up with a device failure. There was a lot of mechanical problems with that. And there is a reversion, or there is a revision of the device came again in 2007 by a different company. And this plicator, when compared against radiofrequency ablations, plication resulted in a greater improvement in regurgitation symptoms. So when they compare with strata, it looks to be better than strata. And then this is still in the market, and the people are working and trying to modify the device to get a better results. Now the third one and the last one is Isoflex X, and this is create an incision-less fundoplication, what we call it a TIF, transoral incision-less fundoplications. FDA approved this clinical use in states in 2007. So more data are available regarding its safety and efficacy because we have already passed 8 years. The device has undergone several revisions, and every time they come up with a new modifications. And this is the device. I'm not going to detail with that because it needs a video. But the obvious thing is, it looks like that you are doing an endoscopic fundoplication. And this is the result of the first trial which came. They say that 56% of the patients cured, 22% improved, but 22% continue to have GERD. But this data is only for 1 year. It has not followed up these patients for a long-term basis. And the thing what they showed in the same paper, that pre-TIF, you will see the hiatus hernia, or you see the lax LES, and then you see 6-month post-TIF, and then you see 12-month post-TIF. Looks that the things are tightening. But the long-term effect after 12 months, we don't know. And this is also the resting LES pressures, that when you compare resting LES pressure from the pre-TIF and after TIF, you will find that there is a significant improvement. And also the use of PPI before and after TIF is completely different. As you see that 67% patients after 12 months did not use any PPI, as compared to 69% in 6 months' time. So this is again okay. So we have got 3 devices which are still in the market. They are doing modifications and revisions of these devices every day and coming with better solutions. So coming to the last one, which is a strata procedures. And this radiofrequency technology was originally approved by FDA in 2000. So it has got almost 15 years in the market. And because of this prolonged stay in the market, you have got a better results about the complications, about the efficacy, and about the effectiveness of the procedure. It decreases the LES pressure. It decreases the transient LES relaxations, and it increases the LES pressure. The number of studies which have been done in last 15 years is tremendous, and you see that it is done on 1,441 patients across 18 studies and 4 randomized trials, and all of them are in favor that it works. How it works, I will show you in our data what we did in King Faisal Hospital. So a strata procedure is recommended in patients who don't want to continue medication for life. They are fed up. They say, we are taking for last 15 years, 10 years. We want something else. So the patient has got a drug intolerance, or patient who wants to try less invasive treatment than a fundoplication, and some patients are scared from the complications of a major surgery. So the following patients, we exclude them, or this is a not eligible patient for a strata procedure: younger than 18, pregnant women, patients without a diagnosis of GERD, large hiatus hernia. Usually we take 3 centimeters, some centers take 2.5 or 2 centimeters, and esophageal strictures. HRM not performed to rule out major motility problem. We don't do strata in patients who did not have high resolution manometry. Eosinophilic esophagitis, and they are poor surgical candidate, or ASA 3 and 4. So the procedural technique is simple. We do it usually started with conscious sedation, but nowadays we are doing under propofol because patients feel more comfortable with propofol, and you can do more specific burn at a particular time, and patient doesn't move it. So we measure the Z line 3 times accurately, what is the Z line, and then we do it accordingly. We go above 1 centimeter and we go 1 centimeter below the Z line. And catheter is guided through guide wire and balloon inflated. Catheter places 4 small needles outside of the balloon into the muscle of the LES and gastric cardia. And we deliver the radiofrequency to the muscles, up to 85 degrees centigrade. And this energy creates a normal lesions. And the idea is that the muscle will tighten and increase the LES resting pressure. Procedure is quite simple. It takes about half an hour to 45 minutes. Patient remain in recovery for 2 to 3 hours, discharge on the same day after the strata. Usually we give PPI for the first 2 to 3 days, and the reason is that we want that the patient should heal the burn of the radiofrequency in the 2 weeks' time. And bleeding is very rare. We have done almost 56 patients. None of the patient has bleeding. And the large trial which have been reported, 126 patients, they have got 1 patient who had a minor bleed, which was stopped without any intervention. So this is the thing what you see when you finish the endoscopy. You see this is the strata antegrade radiofrequency lesions, and the down you see the retrograde radiofrequency lesions. So you burn the lower esophageal sphincter from both sides, from antegrade as well as the retrograde. And there is a recent trial published last month, and they compare the laparoscopic tope fundoplication with the strata procedure, and you see the side effects are not much different between the significantly different, except the pharyngeal pain is more with the strata. Definitely you are going to do an endoscope and then you pass the strata catheter. And also the abdominal discomfort and dysphagia is more with the tope fundoplication, because you close the lower esophageal sphincter more tightly as compared to this, and the patient cannot burp and the patient get dysphagia and other complications. The other recent trial which have been published comparing the Nissan fundoplication and the strata and the safety for after 5 years, and they found that surgery works better than strata, and we accept that. The second one, they compared the full thickness plications compared with the strata, and they found that the plication work better than strata. Okay, so now we have got 1 RF energy device, and we have got a three suturing device. Now coming to our trial in King Faisal, because of this conflicting report, some people say it worked better, it doesn't work better. We thought that we should do a prospective trial in our hospital, and the primary objective was the effectiveness of radiofrequency procedure in PPI refractory patients. So we only selected those patients who did not respond to the PPI. And as you know that the refractory patients, our number is rising. It started with 10%, now 30 to 40% patients are refractory to PPI. So we checked the GERD HRQL, which is health-related quality of life questionnaire. We asked the patient to answer those 10 questions.
Mohammed,
and everyone.
Time is over already.
Yes. An overall level of satisfaction after the RF application. The secondary objection was the reduction of elimination of PPI use. I'll not go in the detail of methodology. It is already there in the poster outside. I'll come to the result. Post-strata stratification score, we asked the patient 5 things. Are you very satisfied? Are you satisfied with the procedure? No change, dissatisfied, or very dissatisfied? And what we found that more than 60% patients, or around 60% patients, say that they are satisfied with the procedure. 17% they did not find any change, but we are worried about 15% patients who are dissatisfied with the procedure. Fortunately, they don't pay anything for King Faisal. If you are doing a private practice, I think these 15% will not let you go home. So this is the patient's HRLQ status before, and you can see that the before the strata and after strata, definitely the number has gone down. And this is the proton pump inhibitor dose. If you see that 19 patients out of 56 continue to have 40 milligram BID, and 15 patients reduced to 20, 15 patients changed to PRN basis, 4 patients completely discontinued the PPI, 1 was dissatisfied and he went for fundoplication. So it's a varying results, but majority of them feels better. Now coming to the proposed algorithm for endoscopic management of GERD in 2016, so if somebody has got a chronic refractory GERD, you assess EGD to rule out mucosal defects, or you rule out a hernia and eosinophilic esophagitis. Do impedance pH monitoring and show that the patient has got either it is a Bravo capsule or impedance pH capsule, that he has got a reflex. Do a normal esophageal manometry, and then you have got 3 options. either go for surgery, go for strata, or you go for transoral incisionless fundoplications. And if nothing fails, you can go for strata. If again the thing fails, you can go for the surgery. And in conclusion, to the chairman, this is the last slide. The refractory GERD patients now have several less invasive options in addition to laparoscopic surgery. So we have got options. I showed you that there are 4 present options available now. The RFA, radiofrequency ablation strata, has been proved effective, safe, durable, following 15 years of worldwide experience. Newer devices, endoscopic plication, suturing, endoclinch, plicator systems, Isofix X, and MUSI have demonstrated mixed outcome and are more cumbersome in some cases, requiring access to an operation theater with inpatient hospital stay, and most of them is done by the surgeons. Injectable treatment results are not promising following several recall products. So we don't advise to go ahead and try injection treatment. Additional research is needed to tailor these newer treatment to a specific patient subgroup with the specific consideration of the risk and benefit of these techniques related to laparoscopic surgery. Thank you for your attention.